And we're going to start this first session in fetal cardiology with Dr. Cleo Laskari, who's a pediatric and fetal cardiologist with a very big experience in fetal cardiology. And she's currently the director of Echocardiography, Pediatric Cardiology, and Adult Congenital Heart Diseases in MITERA Hospital. Dr. Laskari, thank you very much.
Thank you, Dr. Adzaklis. I would like to welcome you all to this international forum. I recently joined the MITERA Hospital Pediatric Cardiology Group, and I'm very happy about that. My talk today is going to be about fetal arrhythmias. Fetal arrhythmias is a very intriguing subject and challenging. Why? Because the fetus cannot actually communicate feelings of distress due to fast or slow heart rates. Also, another reason is because it's in the uterus, and so nobody can take actually a surface ECG. So a diagnosis is really challenging. Another reason, the third reason, is that fetal cardiac output is very highly dependent on heart rate. The normal heart rate for a fetus is between 110 and 160 beats per minute. In order to evaluate the fetal heart rhythm, one has to measure the timing of atrial and ventricular systole. How can we do that? The techniques of evaluating the fetal heart rhythm are 2D echo, M-mode echocardiography, pulse Doppler echocardiography, and fetal magnetocardiography. So this is an M-mode tracing that shows that the cursor actually cuts the atrium and the ventricle, and one can see the atrial systoles on top and the ventricular systoles on the bottom, and one can actually evaluate the timing between atrial and ventricular systole. Another way to evaluate the fetal heart rate is mitral to aortic flow pulse Doppler. Once you put a pulse Doppler between the mitral and aortic valve, one can take a Doppler of the atria and ventricles, and actually find the interval between the atrial and ventricular systole, and one can measure different things like VA interval, AV interval, and other like isovolumic contraction time, rapid ventricular filling times. One can do a lot of measurements with the mitral to aortic flow pulse Doppler. Another way is the SVC to ascending aorta flow Doppler. As you can see, one can put the pulse wave cursor in between the SVC, the superior vena cava, and the ascending aorta. And we can take tracings like in the bottom that shows the atrial and ventricular systole. And in this case, one can see that it's 1-to-1. Another way is the simultaneous pulmonary venous and pulmonary artery pulse wave Doppler, but this is actually a little bit more difficult to perform. Fetal magnetocardiography is a non-invasive technique for recording magnetic fields generated by the electrical activity of the fetal heart. It is analogous to an ECG. It utilizes the extremely high sensitivity superconducted quantum interference device, and this can amplify signals naturally occurring and extremely weak from the fetus. You can get a tracing like this that actually resembles a lot a normal ECG. One can measure the PR interval, the QT interval, the QRS interval, and all this stuff. In terms of fetal arrhythmia mechanisms, they can actually divide it in two major categories. There are disturbances of rhythm production, like sinus bradycardia, sinus tachycardia, atrial extrasystoles, and ectopic atrial tachycardia, junctional extrasystoles, junctional tachycardia, ventricular extrasystoles, and ventricular tachycardia. Another major category of fetal arrhythmia mechanisms include disturbance of impulse, conduction, and propagation. Two major categories: re-entry, like in atrial myocardium, such as atrial flutter or atrial fibrillation, in the AV node, like AV nodal reentral tachycardia, and through an IV, an accessory atrioventricular pathway, such as in atrioventricular reentral tachycardia. Also, there may be blocks such as sinoatrial and atrioventricular blocks. The most frequent referral to the pediatric, to the fetal echocardiographer, are premature atrial conductions. These conductions could be conducted and non-conducted. This is a patient actually that we saw yesterday in our fetal service. And as you can see in the left slide, the left part of the image, you can see atrial conductions, premature atrial conductions that are not conducted to the ventricles. So these can cause atrial bigeminy and may be one of the most frequent causes of fetal bradycardia. On the right tracing, you can see that there is one-to-one conduction from atrial to ventricle. So this, on the left image, the heart rate is like 230 beats per minute. So in these cases, with premature atrial conductions, they are actually very benign. It is a very common referral for fetal bradycardia. It has an excellent prognosis, usually disappears at the end of pregnancy or after birth. There is no therapy needed except for mild measures like such as hydration of the mother or magnesium. One has to do, though, a very frequent follow-up because in 1 to 3%, this can progress to supraventricular tachycardia, to fetal tachycardia. Like in this patient that we saw yesterday, that has intervals of bradycardia because of blocked PACs and tachycardia up to 230 beats per minute. Premature ventricular conductions originate in the ventricles, as you can see in the schematic in the right, and they're very rare in fetuses. They may be benign, but once you see ventricular contractions, premature ventricular contractions, one has to exclude myocardial disease, tumors such as rhabdomyomas, and heart failure. Fetal bradycardia. In fetal bradycardia, the heart rate is less than 100 beats per minute. It can be sinus bradycardia, atrial or junctional bigeminy with non-conducted PACs, as we said in the past, and AV block, which can be high-grade or complete heart block. This is an example of sinus bradycardia, and sinus bradycardia could be transient and vagal due to transducer pressure. We see it very often in echo exam. Once you press the placenta, sometimes that can cause transient fetal bradycardia. Can be persistent due to fetal distress, maternal hypothermia, sinus node disease. Can be primary due to genetic etiology or in the context of heterotaxy syndromes like the left atrial isomerism and polysplenia syndrome. Also, another major cause in fetal bradycardia, which is extremely rare, thankfully, is long QT syndrome. This is a case that shows the mitral to aortic pulsed wave Doppler tracing of 2-to-1 AV block. As you can see at the bottom, the atrial systoles, the atrial, which are actually, you can see it's 133 beats per minute, the atrial heart rate, and the ventricular heart rate is exactly half of it, which is 67 beats per minute, and this is due to 2-to-1 AV block. This can actually progress to third-degree AV block, like in this case. This is an M mode that shows the third-degree. Okay, this is a M mode that shows on the top the atrial systoles and on the bottom the ventricular systole. Heart rate of the atria is 150 beats per minute and of the ventricles 37 beats per minute. So we're back. Okay, this is the slide I was talking about before we lost the connection. This is a third-degree AV block or complete AV block. It's an M mode of a fetus with a complete AV block. You can see on the top of the M mode multiple atrial systoles that are up to 150 beats per minute, and on the bottom a ventricular heart rate of 37 beats per minute, which is very slow for a fetus, obviously. Complete heart block can be isolated or in the context of congenital heart disease. Isolated congenital AV block is usually autoimmune mediated. It is due to maternal collagen vascular disease like systemic lupus and Sjogren's disease. It is actually it can be found in 1 out of 20,000 births, and usually the anti-Rho and anti-LA antibodies are present. The possibility of AV block in the presence of maternal antibodies is 2 to 5%. The possibility of appearance of complete AV block in subsequent pregnancies is up to 15 to 20%. The age of diagnosis is 16 to 24 weeks. That is because the conduction system of the fetus is actually developed fully at around 16 weeks. It is occasionally progressive, and survival is actually 75% in isolated congenital complete AV block. And the indices of poor prognosis are ventricular heart rate less than 55 beats per minute, endocardial fibroelastosis, myocardial dysfunction, and hydrops fetalis. Congenital AV block can be also found in the context of congenital heart disease, like in this case that you can see in the bottom, where you can see congenitally corrected transposition of the great arteries. It is called LTGA, and it can also be found in isolated ventricular discordance. Another cause are heterotaxis syndromes, especially left atrial isomerism, and left ventricular non-compaction. The prognosis is much worse than isolated congenital AV block, and that is because actually only 19 out of 123 fetuses with congenital AV block in the context of congenital heart disease survived, and there is no hydropic fetus that actually survived both of them, congenital AV block and congenital heart disease. The treatment for congenital complete AV block is hydrochloroquine, which is, we call it Plaquenil here in Greece, and it's actually very helpful. And we have seen mothers who had fetal demise in the first fetus, and then with this medication, they were able to complete the pregnancies and have healthy babies. Conflicted results in terms of steroid use and plasmapheresis. Sometimes sympathomimetics like terbutaline can increase the heart rate by 10 to 15%, but this does not have a significant impact on survival. Sometimes you can use ventricular pacing, but this treatment also is very transient, has very transient effect and no long-term benefit. In hydropic fetuses that are older than 34 weeks, one has to deliver the babies and put a pacemaker. Another cause of fetal bradycardia is long QT syndrome that can be actually diagnosed by magnetocardiography. It is up to 75% can cause sinus bradycardia, and another cause of long QT can cause actually ventricular tachycardia and torsade de pointe as well. So 75% of long QTs causes sinus bradycardia, and another 25% shows as ventricular tachycardia. One has to treat these babies, the mothers, with beta blockers, and other medications have been used. And during delivery, it should be a very quiet environment and no stressful stimuli. Fetal tachycardia. In fetal tachycardia, the heart rate is above 160 beats per minute. It can either be sinus tachycardia, and the heart rates in high sinus tachycardia are between 160 to 200 beats per minute, or there may be pathologic mechanisms, and usually these tachycardias have heart rates more than 180 beats per minute, can go up to 300 beats per minute. Causes of sinus tachycardia are fetal distress, anemia, infection, maternal use of sympathomimetics, and fetal thyrotoxicosis. We can see a slide here of pathologic fetal tachycardia with heart rates up to 266 beats per minute. This can be atrial, junctional, AV reentral tachycardia, or ventricular tachycardia. A very common cause of supraventricular tachycardia in fetuses is atrial flutter. As you can see in the left image, the atria contract much faster than the ventricles. And actually on the right image, you can see that a very important indicator of one can diagnose atrial flutter is the movement of the intra-atrial septum, which actually, if you can see it in the 2D image, moves a lot faster than the ventricles. The supraventricular tachycardia, in case it is actually prolonged, the fetus cannot say that I have tachycardia and you should treat me. So one should do a lot of follow-up exams. And in case it is left without treatment, and for long periods of time, it can easily, very fast actually, cause signs of heart failure. In fetuses, signs of heart failure are tricuspid insufficiency, as you can see in the left image, a lot of TR, pericardial, pleural effusions, ascites, and eventually hydrops fetalis. This can be actually seen very fast in fetuses because, as I said before, the fetal cardiac output is very much dependent on heart rate. Another cause of fetal tachycardias, rarer cause, is Ebstein's anomaly. Ebstein's anomaly is when the diaphragmatic leaflet of the tricuspid valve is actually dislocated down in the ventricle. There is a lot of tricuspid insufficiency, and sometimes there are accessory pathways that cause fetal tachycardia. The treatment of fetal tachycardia is to give the mother medications. In case the fetal tachycardia is prolonged, or in case there is hydrops or heart failure. Luckily, the treatment has a very high success rate. It is 50 to 70% in non-hydropic fetuses, and actually has a very high success rate even in hydropic fetuses. The most, a lot of experience is during the years, we have a lot of experience with digoxin, which actually we can introduce the digoxin to the mother in high doses in the beginning and then adjust according to the needs, if the tachycardia has stopped or no, or to the levels. One has to monitor very closely digoxin levels because, as you know, digoxin could be very toxic. So with digoxin, usually, especially if somebody has to give intravenous digoxin, the mother has to be hospitalized. There has to be a cardiologic exam evaluation of the mother by adult cardiologist or by us before one takes digoxin and afterwards. And usually, from our experience, it may take a little bit longer to stop the atrial tachycardia with digoxin than with other medications, such as Flaccinite. The second used drug, most common used drug is Flaccinite in a dose of 100 milligrams every 6 or every 8 hours. In the beginning, this Flaccinite was used as a second-line drug, but now one can use it as a first-line drug, especially in patients that one wishes to give medications at home and not in the hospital. Anyway, even if if the mother takes Flaccinite, she has to have a cardiac examination as well, and has to have her ECG monitored very frequently in the beginning, because, as you know, Flaccinite can prolong the QRS. One can use also drug combinations such as digoxin plus Flaccinite or digoxin plus amiodarone. In the hydropic fetus, direct fetal therapy can be introduced, like intraumbilical digoxin, Flaccinite, or amiodarone. In conclusion, fetal arrhythmia can be diagnosed accurately with fetal echo, based on the timing of atrial and ventricular systole. The most frequent referrals of fetal arrhythmias are premature atrial conductions, which, as I said, have a very good prognosis. Sometimes they can progress to SVT, to supraventricular tachycardia, and this SVT has to be treated. Also with treatment, supraventricular tachycardia has excellent prognosis. The treatment depends on the etiology and severity of the tachycardia or bradycardia, of the fetal arrhythmia. And first-line treatment is given to the mother and to the fetus transplacentally, but also in some cases it can be given through the umbilical veins and directly after emergent delivery. Thank you.
And thank you very much, Dr. Laskari. That was an excellent presentation. I think we will keep all the questions and the queries for the discussion session, which is between 10:30 and 11 o'clock. So we can proceed with the next speaker.